Now, endocrinology of critical illness, it's something that is we are looking forward to hear in this session. I think endocrinology of fatigue and love and other things, we want to know what people are going to talk about it. We are really excited about it. Dr. VP Praveen, I got an immense pleasure to introduce him. He's additional professor in endocrinology, and he's from Amrita Institute of Medical Sciences in Kochi. With that, I'll hand over to him.
Thank you, Chairpersons, for the kind introduction. Good afternoon, everyone. My sincere thanks to the organizers for this opportunity to contribute to the scientific program in this August conference.
Before, sorry about that, I think we'll do 20 minutes each, and then we'll have a question and answer sessions after that together.
Right.
So we can mix love and fatigue together.
Sure. Great idea. Can I have the slides, please? Yeah. So just to start off, endocrinologists are mostly peaceful people. And I don't think most of us enjoy going to ICUs and looking after critically ill patients. But there are a couple of reasons why endocrinologists should be acquainted with the endocrine changes which occur in critically ill patients. And these are some of the compelling arguments. Critical ill responses may be misinterpreted as endocrine disease, and sometimes worse situation. Endocrine disease may be misinterpreted as a critical illness related change. And of course, we are to be abreast with the latest developments, therapeutic interventions which require endocrine opinion. Now, response to severe physical stress is something which has evolved over millennia. And critical illness, by the way, is defined as a situation in which the critically ill situation in which you require some sort of external support to survive. And of course, this means that most of our hunter group of forefathers wouldn't have survived a critically ill situation. And most of the response of the body to a critical illness is orchestrated by the endocrine system. And the focus is on survival. The vital organs are given importance, and of course, the immune system has to work optimally. Things changed with the advent of ICUs in the 20th century. More and more people started surviving. Of course, this is something which has vexed us for many years now. Is the nature tuned to dealing with or other coping mechanisms for prolonged critical illness? Because many of these patients are in a hypercatabolic state. Are there natural coping mechanisms which help them to come out, or do many of them need a bit of help to come out? And this is something which I'll try to address during the course of the talk. And during the next 20 minutes or so, I'll be just dealing with three things. What are the physiological alterations which occur, endocrine physiological alterations which occur in critically ill patients? What are the diagnostic implications? What are the therapeutic implications? And of course, before going into the topic proper, one has to be very clear that interpreting hormonal values in the face of critical illness has a number of problems associated. For example, the basal levels are very much unreliable. The feedback loops are disrupted. There is a problem with assays because the binding proteins are sort of destroyed by the critical illness response. The free hormone estimation may be problematic. It's a dynamic state. Things keep on changing hour by hour. And of course, the same person may have different values depending on when you do the sampling. And of course, one has to reckon with the drug effects, the multitude of drugs which are used in modern ICU. Let's start off with thyroid. All of us know that one of the first responses which occur in a critical illness is a decrease in the T3. T3 goes to very low levels, and once the patient recovers, it comes back to normal. Once the illness lasts for a few days, TSH also starts getting suppressed, and in the recovery phase, there may be a phase in which TSH may go above normal. About T4, there may be a phase in the first couple of days where the T4 or few hours where the T4 may actually go up. And then when the illness is prolonged, the T4 usually goes down again to come up when the patient recovers. For many years, we were under the impression that all these acute responses were mediated by interleukins, but we now know that these responses are mostly mediated by a simple mechanism, that is starvation. Of course, there are other players like increased bilirubin levels and free fatty acids, but most of it is mediated by starvation. By unknown mechanisms, these lead to over-elaboration of D3, that is a deiodinase 3, and also underexpression of the D1. And of course, as a result of increase in D3 activity, you have more generation of reverse T3, and suppressed D1 leads to decrease in T3 levels. And of course, this is advantageous because it causes lowering in the metabolic levels, and so that the body can concentrate on vital organs. Something which is rather intriguing is that there is increased expression of D3 in the polymorphonucleosides. We are not exactly sure what happens. Probably it has to deal with the mechanism that because of increased D3, there is increased release of iodine, which helps in fighting the microbes. And in prolonged illness, there is suppression of the hypothalamic axis. The TRH is suppressed, and part of it is mediated by fasting as well. The leptin has a role in stimulating the TRH secretion, and with fasting, the leptin levels go down, and so there is suppression, hypothalamic suppression in prolonged illness. The point about refeeding, that is early introduction of parenteral nutrition, was studied in a couple of trials because people thought that when you get an acute illness, most of the patients have decreased appetite. And there were there were two groups. The Europeans believed that probably we should take care of the nutrition first and give them the standard quota of nutrition, probably more to take account of the illness. The Americans thought that probably we had sort of tuned down. So there were these couple of trials which were done, and this question is now elegantly answered. Increasing the nutrition in the early phase of illness actually increases the mortality, and it has been highly correlated with the levels of T3 and the T3 to reverse T3 ratio. This is a comparison between late parenteral nutrition and the early parenteral nutrition. So there is a direct correlation with the levels of T3 in multivariate analysis. In chronic phase, something extra happens. There is increased elaboration of the deiodinase 2, which results in increased formation of T3 within the tissues, and that probably has a role in suppression of the TRH. But at the level of tissue, something strange happens. Although the T3 goes down, there is increased expression of the transporter molecules like MCT8 in organs which are metabolically active, for example, the liver. The thyroid receptors are expressed more, and of course, there is enhanced T3 to reverse T3 levels. Now let's go on to some of the diagnostic implications of what we have talked till now. This is a 65-year-old lady admitted in ICU for pneumonia on ventilator. You can see all the levels. You can see highly suppressed T4 and T3, almost undetectable, with a slightly elevated TSH. So this is one situation in which if you are not careful, you can label the person as having sick thyroid syndrome, but if you look carefully, just a recap of what we have talked till now, the T3 goes down all along and comes back only at recovery. Free T4 may be normal, can go up transiently and then goes down. River 3 always goes up, and the TSH very rarely it goes up in the acute illness. Most of the time it's either normal, and once there is prolonged illness, it goes down. So here we have a patient who has really suppressed or undetectable thyroid hormone levels with slightly elevated TSH, which is supposed to be suppressed. So this patient is highly likely that she's having a primary hypothyroidism with a falsely modest TSH elevation. So she should have been having some levels of around 40, and because of this acute illness, it has been, it has been suppressed and it has been reported as age. One of the tricky situations one is called upon to address is when a thyroid function is done in a patient who has been in ICU for around 1 week or 2 weeks. The problem is in differentiating between sick euthyroid syndrome and central hypothyroidism. All the 3 levels are suppressed: T3 low, T4 low, and TSH is also suppressed. So it's a difficult situation. Of course, we have to, there is no easy answer for this. There may be clinical features, like for example, there are features of mixed edema, it might help. Presence of goiter or ultrasound evidence of goiter will help you. Presence of high titers of antithyroid bodies, that's just an ancillary investigation. And having high levels of reverse T3 and high T3 by T4 ratio will also help you. The reverse T3 estimation, reliable estimation, is done only in few labs. So most of us it's accessible. So it's a bit of a problem, but the high T3 by T4 ratio may help you. And many times, repeated testing is needed to make a foolproof diagnosis. And of course, one has to always remember the effect of drugs. Steroids and dopamine should never be forgotten. Both of them suppress the TSH. Is there any therapeutic benefit in the use of thyroid hormones in critically ill patients for the lower levels of hormones? This has been conclusively answered. There are no benefits of T3 and T4 in critically ill situations, but there is some improvement in cardiac function after IV T3 administration. We are not very sure whether it's a pharmacological effect. And just taking one step further, we are talking about hypothalamic suppression, which occurs in prolonged illness. People have tried hypothalamic releasing factors to see if it would help. These are small trials pioneered by Vandenberg from Belgium. And they have used releasing factors GHRP2, growth hormone releasing peptide 2, and TRH, small set of patients for 5 days, and found that there is decrease in catabolic responses. But of course, this was too small a study to look at any survival benefit. And of course, I think they are in the process of planning a bigger study to look at this aspect. Until then, it's an open question. So I think it's pretty clear about thyroid. The acute T3 response is an adaptive response. We are not very clear whether the chronic response, that suppression in all the hormones seen in chronic illness, is adaptive or maladaptive. Let's jump on to the adrenals. So let me just, for those who are uninitiated, let me introduce you to the concept of relative adrenal insufficiency. This is something which was pioneered in 1990s and which was put on a firm basis based on this study. This is a French group, Anin et al. I think this was published in 2000 JAMA. So what they found is that the concept is very simple. Even in patients with seemingly normal responses to critical illness, they found a subset of patients who had synactin stimulated, the cosentropin ACTH stimulated cortisol response of less than 9 microgram per deciliter. They found that these patients had higher risk of mortality. Of course, they also found that patients with very high basal levels, probably indicating the amount of stress, they were also significantly at risk of higher mortality. They followed this study with a larger study which looked at the mortality benefits, and they found that these patients having a poor response, less than 9 micrograms per liter, had a mortality benefit in this large multicentric French trial. They also found that there was early reversal of the septic shock. So there are a couple of other studies which supported the same with regards to the reversal of shock, but there was no mortality benefit in these studies. So it seemed like, every patient with septic shock, for some time it seemed like using steroids would be a good idea. And the Cortica study was designed to answer this question. And this is a large trial, multicentric, around 499 patients. They found that there was early reversal of shock, but there was no mortality benefit in this patient. And they found that there was no mortality benefit in those patients who responded poorly to the SST, that's the synactin stimulation. So this is a classical view of what happens in a critically ill patient. This is what we have in our mind. Critical illness means a lot of ACTH on board, a lot of cortisol gets secreted. But now the things have changed slightly. We know that the ACTH is not always elevated in these patients. In the first 48 hours or first 2 to 3, 4 days, it may be elevated. After that, the ACTH levels need not be very high. The increase in cortisol is now thought to be mostly related to the decrease in metabolism. Two key enzymes which are sort of inhibited in a critical illness are the reductase and the 11-beta-hydroxysteroid dehydrogenase 2 in the kidneys. And because of this decrease in metabolism, the cortisol levels go up. And the non-ACTH dependent adrenal stimulation is now thought to be probably mediated by the interleukins themselves. Now, the one question which has not been answered is that whether in a prolonged illness, for example, a person who has been ill for probably 1 month, whether all this increased cortisol will inhibit the ACTH and lead on to a state of mild secondary adrenal insufficiency. We are not yet very clear about this. And some of the recent developments in the relevant physiology related to critically ill patients, there is wide variability in random cortisol levels. So we all have this concept that you can just take one sample in a critically ill patient, or say that this patient is in sepsis, and you're taking it on the 4th day, and you find a cortisol of 10 or 12. You tend to label them as adrenal insufficiency, but this study clearly tells you, this is by Venkatesh et al. Done in Australia. They clearly, and the levels are in nanomoles per liter, so the conversion would be around 28. You can see that this is a patient who has septic, being treated for sepsis in ICUs. I think there were around 20 patients in the study. They found that the levels may be as low as less than 10. So, and there is no clear circadian rhythm. So, using random cortisol levels to diagnose adrenal insufficiency in these patients may be erroneous. And as I said earlier, ACTH is not always high. A lot of other issues associated with diagnosing adrenal insufficiency in these patients. One of the key factors is poor assay performance, and the total cortisol poorly correlates with severity. The cortisol, as you know, is bound to the cortisol binding globulin, and in critically ill patients, especially sepsis, there is a breakdown of the CBG. So more correlation was found with the free cortisol levels, which are not easily available. So more than the total cortisol, it's a free cortisol, which is important. And of course, as I said earlier, there is increase in local cortisol levels to a number of factors, like, for example, decreased metabolism. And also, I told you about the inhibition of 11-beta-HSD2, which is involved in the conversion of cortisol to cortisone. The opposite thing also happens, 11-beta-HSD1, which is involved in the activation of cortisone to cortisol. That also happens, resulting in increased local levels. But another important thing is that some of the tissues were found to have decreased glucocorticoid receptors and also glucocorticoid response elements. So here you have a situation in which the blood cortisol levels are high, the interstitial levels are high, but some of the tissues are selectively protected from the actions of cortisol, especially with related, for example, things like polymorphonucleosides, lymphocytes. They have decreased expression of the G-alpha. So that this challenge is because, as I showed you earlier, there is a trend towards higher mortality even in patients with high cortisol levels. So that could not be explained if you say that the patients with poor response should have high mortality. So that is counterintuitive. And there is no increase in mortality with lower levels. I'm sorry that I missed the p-values here, but you can safely say that the black bars are the levels in patients with a higher mortality, and they showed that there is no clear difference between patients with cortisol levels and the mortality in critically ill patients. We are not talking about garden variety adrenal insufficiency here. Let me conclude the adrenal aspect by quoting the Surviving Sepsis Campaign Guidelines, which was published in 2012, republished rather. So the only situation where intravenous hydrocortisone is used is refractory hemodynamic instability. That means there is hypotension despite use of fluids and vasopressors. The intravenous hydrocortisone dose is around 200 milligram, and it's better to use it as IV infusion. And in treated patients, when the vasopressors are no longer used, it should be tapered and stopped. And they have recommended against using ACTH stimulation test to identify adults with septic shock who should receive hydrocortisone. Now, this is something which has been discussed in various forums. I am sure all of you are well aware of this. Just a recap of what you know. Hyperglycemia in the critical ill patients, of course, these were largely brought forth by two classical papers from Belgium by B.T. Vandenberg. Her group, in two separate studies published in 2001 and 2006, done in medical and surgical ICU patients, showed that having a near normal glycemic status, defined as 8 to 100 mg/% had a significant morbidity benefit when compared to patients having levels more than 215. The mortality benefit was demonstrated only in the surgical ICU patients, but could not be demonstrated in the medical ICU patients as a whole, but it could be demonstrated in the surgical, in a subgroup of medical ICU patients. This study was so influential that it changed the pattern of glycemic management ICUs over the course of the next 5 to 6 years.
Dr. Praveen, I think it's 20 minutes.
Yeah. Can I take 2 minutes?
I think maybe a minute.
Yeah,
so we can.
That's fine. 1 minute is fine. So the NICE sugar study finally answered this question, a larger multicentric trial, and showed that there was higher mortality when you try to achieve these sort of levels, and it was probably related to the hypoglycemic increase in the hypoglycemic events. So the target for critically ill patients should be 140 to 180, and when you try to achieve lower levels of sugars, it may be associated with increased mortality. There are other less important aspects of critically ill patients. For example, vitamin D status, significance is unclear. Growth hormone replacement is beneficial only in patients recovering from burns, and metabolic syndrome in critical illness is being studied. So summarizing what I have told till now, there is expanding knowledge of the endocrine physiology and profound diagnostic implications, and the interventions are recommended only two situations: the hydrocortisone for refractory septic shock and the maintenance of the glycemic status. In the chronic illness, the efficacy of endocrine intervention remains to be studied. So just to breaking it down, so the nature's first priority is survival. Everything which happens in acute illness is adaptive. We don't have to go and interfere, but we are not yet sure what happens in chronic illness. Whether we should interfere in a couple of patients is an open question. In a subgroup of patients is an open question. Thank you very much for the patient hearing.